So this is Todd Hensman. He's a nurse practitioner and partner here at Vitality Anti-Aging Center. And I'm Courtney Browning. I'm one of the PAs here, and we're answering all of your questions about compounded semaglutide today. So at Vitality, we have a really successful weight loss program. We have options for pretty much any patient. So the lipo B12 injections give you a little bit of energy as you're going through the weight loss journey, and pretty much any patient can benefit from that. We also have compounded semaglutide, which is really popular right now, and oral phentermine, which is a stimulant. So we have tons of questions about the compounded semaglutide, and we're going to answer some of those today.
That sounds fun.
Yeah.
Yeah, we've been, we've had a successful weight loss program probably since 2008. We've been helping people in the community, with just learning how to live a healthy lifestyle. Because that's, when you're thinking about weight loss journeys, a lot of people do have an up and down pattern with it. And so while that's understandable because life will happen, from time to time, we do have a structured support system and accountability set into our program to help people achieve those goals, but also maintain the goals. So that's important. We don't just have people lose weight. And so, we've been doing this for quite a while, and we feel like we've got a good process in the fact that we want to be there for the patient, help the patient, stay on track, because a lot of it's not a knowledge deficit. If you ask the patients, some of the routine things they need to do to lose weight, they kind of know. It's some things may be new to them, but there's a lot of information out there, and sometimes that can be overwhelming. So, that allows us as medical providers to be able to, really, dive in and answer questions and kind of shift away from some of the maybe not so good information and help people get into, the more helpful information for longevity. And the compounded semaglutide, the GLP-1s have been they've kind of been a game changer, in not only in the diabetic realm, which is where they were originally researched and utilized, but in now certainly in the weight loss realm. Yeah.
So, what is a compound?
Okay, so it's a great question. So, when you look at the name brands of semaglutide, Ozempic and Wegovy, they are made by a pharmaceutical company who went through, paid millions of dollars to jump through the hoops of the FDA to get a licensed trade name medication. The generic version of that is semaglutide. Now, I don't know, in my medical practice, we have a lot of shortages from the Ozempic and Wegovy, and so the FDA and the medical boards of most of the states have allowed compounded semaglutide to be made by compounding pharmacies. We get ours from Olympia. It's a well-known 503B compounding pharmacy, meaning they are held to very strict standards, and they are able to produce this in a way that gives you the exact compound, but they didn't have to go through the FDA trials and the expense that the major pharmaceutical companies did.
So that the pharmacy has met requirements and standards by the FDA to compound that medication.
Yes, they are monitored, and usually there is purity testing that's done along with it, and so I feel very comfortable. I've used compounding pharmacies for years, even when I worked in emergency medicine. There sometimes we would do compounded tetracaine lollipops for strep throat. So compounded medicine's been around for a long time. It's well established, and not to take anything away from the traditional pharmaceutical companies, but it is an option, particularly in a shortage situation, to where we can get these medications to people, and that'll be very helpful for them for not only weight loss, but the overall health benefits of the weight loss.
And as far as compounded semaglutide, how does it work?
So the GLP-1s, now semaglutide is a single peptide molecule. It works several different mechanisms. One, it helps increase insulin secretion. some people with weight loss, sometimes they have higher insulin levels, sometimes they have issues with insulin sensitivity. But this one actually works in the liver in the liver, with the pancreas and the beta cells. So we know with diabetics, a lot of times that they will have what's called apoptosis, which is signaled cell death of the beta cells. Now you see this aggressively with type 1 diabetics, but in type 2 you can have a decreased amount of insulin production, and the mechanisms will signal cell death for the beta cells. The interesting thing about GLP-1s is they will reverse that. They actually will upregulate beta cell production and decrease apoptosis, so you can have a better insulin release to your glucose level, so you have better control. So people with insulin resistant, people who are diabetic, it tends to help with that. It also decreases some of the glucose output from the liver. So this is important. Diabetics sometimes, and people who are overweight, have issues with extra sugar release from the liver, and so this blunts that. One of the big things it does is that it stimulates some receptors in the hypothalamus that helps activate satiety, meaning to help you feel full. And this is interesting because not only does, in the research trials of the trade names, they noticed that it helps with a lot of different things. It helped with weight gain. It certainly helps with diabetes. Now we're finding out cardiovascular protection with them. But it also helped with addiction. And I think that goes to, in some cases, we use food as a coping mechanism. Absolutely. And so, I mean, seriously, I've been guilty. And so, what you have is you have a medication is able to work on multiple aspects of how people gain weight. But it also affects the brain to make you feel fuller faster, and to keep that kind of activated so that the cravings don't get out of hand. And so that is, there's still some more stuff that does in the background. That's kind of the big three ways that it really helps people, lose the weight.
Okay. Yeah, and as far as the insulin, decrease in the insulin resistance, it's not one that typically causes low sugar, so it causes
exactly. So it's very safe not to cause hypoglycemia or low blood sugars. So the only way that you'd run into low blood sugars with this is if you were prone already to have hypoglycemic episodes, which the treatment for that is that you eat more. And so if you were a known person who had hypoglycemia, then in the consultation we would say, hey, look, this medicine is going to make you want to eat less, but you need to schedule times to eat, or you could run into low blood sugars. And it's not from the medicine, it's from them not eating. Which is
really uncommon anyway.
It's very uncommon, but it's something that we would ask because this is medical in the consultation whether they had any issues with it.
So as far as what are other side effects potentially of the medication?
So the side effects are mainly, a lot of them's GI, side effects. One of the other mechanisms is delayed gastric emptying. I'm not sure how I jumped over that, but so it does slow the emptying of the stomach. So it can increase sometimes some reflux, it can cause some nausea. Sometimes it can cause constipation or diarrhea, or sometimes alternating, just depends. Sometimes there can be bloating. This usually is during the activation stage and also increasing in doses. So when we prescribe this medication, we start with a very low dose because we want to basically get your body sensitized to it, to where it is adjusting. If we started you at therapeutic doses, no one would tolerate these medicines. And so we know to start low and go slow. And sometimes it can be a little frustrating for some of our weight loss people because they're looking for that. Everybody wants a quick fix, right? I mean, who don't? I love a quick fix. But with weight loss, and particularly these medicines, there are two types of patients that we see a lot. One is the true overeaters. And so when you have someone who truly overeats, if you put on anything where they cut their calories, they're going to lose weight relatively quickly. Now, some of that's going to be fluid mobilization from the extra carbs and some of that stuff. Some of it will be, an actual calorie deficit. They will dive in their fat stores because it's a huge change to the body. The tougher patients, I feel, are busy ladies, I tend to find. The guys, typically they're overeaters. They just are. But my ladies, on the other hand, they come in two packages. And some of them are overeaters. Some will come and tell you, yeah, I'm an overeater. I will eat a bag of chips, and they're just like, it'll be gone, or whatever their cravings are, you know.
Right.
But then I have other ladies who have been dieting for 20 plus years, and they have trained their bodies to live on a very low calorie, lower than what the FDA or USRDA would recommend.
Right.
And so their metabolism is already not that great. And so we have to walk a tight line of making sure they're adequately nourished with good quality food while they get this weight loss journey started. And some of that may not kick in until maybe the second, third month of escalation. The therapeutic dosing is somewhere between the 2.5 range, and we start people off at 0.25. So, and again, this is for tolerance. Now, again, some people will lose weight very nicely in the first month or two. Usually that's going to be my overeaters. Some people we have to encourage and coax them along and realize, this is short-term pain, long-term gain.
Right. Yeah, you don't want to start having those side effects. And I explain to people too, even though you're getting 0.25 weekly for that first month, the half-life of the medication is about
actually
a week.
Longer.
So even after a week, you still have 0.125 in your system, and you're adding another 0.25. So it compounds.
Yeah, and it's also nice if, and the way it, kind of accumulates. The longer you're on it, the longer it stays active in your system. And so if you did end up having to miss a dose, or if it becomes a little more forgiving over time.
Right.
And so you can start back, patients who went out of town, forgot their dose, it's okay to start them back. It's a little rougher in the first little bit when they're first getting started. Once they've been on it, they have a very nice, slow roll off. So there is some, it's not preferred, but there's some wiggle room if there happens to be a hiccup.
Right.
It's not like we have to start over.
Yeah.
Which is nice. You don't want to start back at the 0.25.
And I think people hear like horror stories too about side effects, and there's all these different side effects. But we have those GLP-1 receptors throughout our body, so there's a broader range of potential side effects that you could have. But that's why I really like our program, because we have people come in weekly. So the monitoring and accountability is really important. That really eliminates a lot of issues with side effects.
And the other thing is, one thing that we've always recommended is higher than average protein intakes. The USRDA recommends about 60 milligrams of protein a day for the average adult. Well, they did that research in the 50s on college students who were couch potatoes. The actual muscle turnover ratios, most people need probably 80 to 100 milligrams. Men who work out or women who work out, they may need more because they need a positive nitrogen balance. But one thing we can do is encourage patients, and it's a little tougher in ladies because by nature, they're not necessarily as drawn to the meat. They're drawn more to the carbs for whatever reason. And so having those adequate protein has been shown to decrease the muscle loss effect. And this isn't unique to GLP-1s. Okay, anybody that loses a large amount of weight is going to lose muscle mass. It is physiologically impossible to lose weight, body fat, without losing some muscle. What we want to do is slow that progress as much as possible so that you retain as much calorie burning, good, healthy muscle and maximize the fat loss. But it doesn't matter whether you're an elite athlete, whether you're a couch potato. If you go on a diet and lose weight, you're going to lose some muscle. You can't, it's just physiologically impossible to do it because muscle is very expensive to keep alive. And when you're burning calories or you're taking away calories, you don't have as much to go around. And so, but it is important because you'll read muscle loss is a big issue with semaglutide or GLP-1s, and it can be. But we can buffer that with education and encouraging our patients to get adequate protein. And of course, staying active. I mean, we should be doing things that we know are healthy to do so that these results are maintained and ingrained into a healthy lifestyle. We want our patients to live healthy, have a well-balanced life, and hopefully live healthy longer.
Right, yeah, those lifestyle changes and habits are still part of the program.
Oh, absolutely, we certainly encourage that.
Yeah. Who would be a good candidate for compounded semaglutide?
So we do have general recommendations, right? The traditional recommendation for diabetics would be, if you were considered diabetic through a hemoglobin A1C higher than 6.5, or if you had a fasting glucose that was higher than what the expected is, or 2-hour fasting, oral glucose tolerance tests. But the indication for weight loss is a little bit different. Okay, you don't have to have an elevated hemoglobin A1C. Now you may have a mildly elevated, but in general it's going to be a BMI over 30, which puts you in an obese category, or a BMI of 27 and a comorbidity related to health. Now that can be cardiovascular, it can be osteoarthritis, it could be knees, it can be various other high blood pressure, PCOS, those kind of things.
Yep.
So you just have to have that, 27, it's the general recommendations.
Right. Okay.
And then we typically will monitor, and I've had to stop some patients, that have really lost a lot of weight.
Yep.
And so that's an interesting conversation.
Yeah.
Because we don't want people to get to, lose too much weight. I mean, there's
Absolutely.
a healthy weight zone that we need to stay in.
Yeah.
And so that's a conversation. But fortunately, by that time, they've met some significant strides and goals, learned a lot. So that conversation is a little easier, and we can kind of work on weaning things down and kind of tapering them off, at that point.
And who should not take the medication?
So if you have someone who's diabetic, who has severe gastroparesis, probably not a good candidate. I mean, you'd have to weigh the risk-benefit ratios. Someone has a lot of GERD, huge hiatal hernia that may need to be repaired. I mean, you can get, with the delayed gastric emptying, you can get into some trouble with that. Interesting enough, when they did the research with Victoza, which was one of the original GLP-1s back in the early 2000s, they would dose the rat models with 1,000 times the human dose, and they noticed an increase of thyroid medullary cancer. And so it's translated over into the FDA safety profile, and so if you had a history of thyroid medullary cancer, we would not prescribe the medicine for you. It's not a good idea.
Yep.
Now, we don't know. We actually, so far, have not seen it in humans.
Right.
But since it's in the safety data, we would certainly stick to the safety data and do what's medically appropriate.
Yep. Obviously, pregnancy or breastfeeding.
Well, yes, pregnancy, breastfeeding, yes. We'll wait till after the breastfeeding until we would do the weight loss, yes.
Yep.
Yes, those are the obvious answers there.
Yeah.
And so the list is not terribly long.
No.
A lot of people can benefit from it.
Yep.
But there's a few flags. People with recurrent pancreatitis, not a good candidate.
Yep.
Pancreatitis is extremely rare but noted, and so it's something that we would monitor for, particularly if you decided or developed left-sided, abdominal pain while he's on the medicine. We'd want to, check some labs, because it has been documented in the safety profiles.
Yeah.
But it's small. It's a small risk.
Yeah. Yeah, and so the goal of the medication would be, if you don't have any of those issues, certainly the risk of a side effect in most patients is much lower than the benefit of lowering the weight to prevent hypertension, to prevent progressive diabetes and heart disease.
I totally agree with that, because, it's frustrating for a medical provider, and I understand the company's going to make money, right? And that's a whole other issue. But when you look at insurance coverage for this, there's such a short-sighted gain, and we won't spend long on this, but I mean, there's frustrations with other medicines as well. They would benefit a lot of people, but they cost too much, the insurance won't cover it.
Yeah.
And so with these medicines, if you're paying out of pocket, you're paying about a minimum of $1,000 to $1,900 a month. Our program's less than that. It's a good bit less, like $400 a month, for the program. So that's one way that the compounding has been beneficial. We can get the medication into the hands of people who would benefit from this medicine at a cheaper price.
Right.
For now. And so, to me, it's a great, it's just kind of a no-brainer.
Yep. I think most people know that it's administered. It's a subcutaneous injection. It's not painful or anything like that, and it's once a week. What can patients expect when they come in for a consultation?
So the general consultation, the general health history, we'll go over a medication list, we'll go over eligibility, we'll do the weigh-in, we'll see if you meet the criteria. I mean, if you already have a BMI of 19, you're not
No.
That's not it. We need to use Cool Sculpted.
Yep.
You know, if you got some pocket areas, we got something for that too, but that's not going to be a candidate.
Yep.
So, you know, if you meet the criteria, you'll get education about kind of what we think is a good diet regimen. Now, we don't do prescribed menus because there's so much variability, and we do want some accountability for the patient to learn how to eat a healthy lifestyle. We give nice general guidelines. As far as what to eat, how much to eat, you know, that kind of stuff, and good food groups. And I get a little booklet, you know, that goes over that with them, and we go over it with them.
Yeah.
And then the good thing about the weekly follow-ups is you have weekly weigh-ins, but you also don't have to wait a month or 3 months for questions to be answered. You know, you get that frequent touch point of care.
Yep.
And so questions can be answered quickly. We can give ideas about how to get things moving. And then we can also, you know, give little quizzes, because commonly what I would see, this is before the semaglutide, but probably still so, is everything works great for the first 4 to 6 weeks. About 6 weeks, we start noticing the weight plateauing out. Well, when we start doing diet journals and start asking, you know, just a 24-hour journal, what are you eating and what's your typical, then what I find is the carbohydrates tend to slip up and the protein tends to slide down. We start returning back to our normal habits.
Yep.
And then the weight loss stops, or, you know, definitely slows down.
Right.
And so we can come up with creative ways to, you know, help. But also it brings awareness, so that the client can actually get back on track and get those ratios back in proportion where they can lose weight better.
Yeah. Yeah, it's a journey.
It's a marathon. I mean, it really is. And so having that extra support and point of contact from a healthcare provider and a coach that really, you know, understands and wants, you know, we're on your side. We want you to win. And we want you to meet your goals. That's the whole reason we get up in the morning.
Yep. Yeah. So yeah, do you get any other common questions? I think those are the main ones I get.
No, I think those are, you know, the main one. I mean, we get some about tirzepatide, but the side effects, everything else on it's going to be very similar to this. It is a dual peptide, so it's got another GIP in it, GIP.
Yep.
And we're looking at bringing it on, so that's something that's, you know, possibly, you know, in the works. And so its trade name would be Bonjero or Zepbound. And then there's a tripeptide coming out on the market in the next year or two. So we're learning more. Yeah, I mean, it's, you know, the technology is really increasing. How we understand the body, how it works, you know, it keeps increasing, and so hopefully we're able to continue to bring, you know, the best, you know, that there is out there to our clients, and keep them, you know, in a healthy way to lose weight and have a healthy lifestyle, and in turn enjoy a healthier, longer life.
Yep. Awesome. That's the goal.
That is the goal. And if there's any more, you know, for anybody that sees it, send the questions in to, you know, to our email.
Yep.
There should be a link on the website, and you know, I'll be happy to sit down. It's always a pleasure to sit down with Courtney and talk about some stuff. So, yeah.
Thanks, Todd.